Good day, nurses. We're here to talk about care of patients with advanced heart failure. Specifically, we're going to talk about providing care to those heart failure patients who are close to the end of their life, which you would usually call hospice care, and those who are not that close but really suffering a lot, and that would be your broad definition of palliative care, which encompasses or includes hospice care. So, as you know, I do a lot of end of life care teaching for students, nursing students, and even pastoral students and priests from around the area ask me for talks and lectures. And I'm also fairly active in the ethics cases in the hospital. And a few of them would be related to things concerning advanced directives and hospice care. But today we'll talk about heart failure. So just to get you your minds oriented, I'll use history. I like using history. So 1950s, when you think about nurses and doctors and the ideal kind, when people started wanting to take care of sick people, then you have these healthcare professionals or professions curing, caring, and there's no difference between cure and care. It's the same thing. So you cure, you care, you comfort, you feel bad, and that's pretty much the original idea of having doctors and nurses doing their job. And then in the 1950s, fortunately or unfortunately, we had this somewhat of boom in medical science and technology, and it became very industrialized and commercialized. And suddenly we have this huge, big institutions coming up with all sorts of pills and drugs and interventions and machines, and people go there thinking that that's the only way to go. Science is the in thing during those times. That's the 1950s and the 1960s, and the doctors get to figure out if you're going to live or die. And the good thing about that is part of it is real. Of course, a good part of it is not that real. It's like part marketing. It's a commercial enterprise. It's becoming a commercial enterprise. Right now, it's obviously a commercialized enterprise, regardless of what the industry tells you. Meaning, it's meant to earn money. But anyway, during the 1950s and the 1960s, the physicians mainly would think that medicine's probably the main goal of being a doctor is to save lives and cure lives, and that's pretty much it. If you're smart enough. Now, if you're not that smart, then you'll probably just do the caring part. But who wants to do that? So ultimately, nobody really does anything to advance the care of people who are terminal, meaning who cannot be cured. So because you want to cure people, you're great, you're smart if you can cure people. If you cannot cure people, then that's failed. And why would you keep people in great institutions who will die? I mean, that's just those are you just send them out of the hospital. And that's actually the thing that drove the pioneers of hospice to create hospice care, which is actually just putting things in order. If you're a doctor and you're a nurse and you're trying to help cure this patient, and you cannot cure them, it doesn't mean you're not supposed to take care of them, right? So anyway, hospice and palliative care would be those small group of people who thought there's something wrong with the entire thing. Now, that brings us to the hospice, palliative care, and curative and life prolonging care. The good thing about this is we got the taking care of the people we cannot cure part. The bad thing about this is people started thinking that's a separate thing. Like most of us will do the curing and life prolonging part, and a few are crazy enough to throw away all their hard work in medical school and nursing school can do the taking care of the people who cannot cure part. Of course, that's a bad way of looking at it, but it became a separate thing. When ideally, if you're going to take care of someone and it didn't work, you should continue to take care of that person. Firstly, you know that person well enough. Secondly, you probably have a good idea. You have a good idea how you can control the progressive worsening symptoms because you are pretty familiar with the disease that's going to kill the patient. Now, of course, later on, near death, everything is the same. It's just multi-organ failure, and you just give anything that works to calm down the patient and make the patient comfortable. And mostly during that time, it's just usually sedatives and narcotics or opioids. I mean, near the end, you can't do anything. Everything's going bonkers. What else can you do? So just give the patient drugs or give the patient the narcotic or the opioid and maybe sedate the patient if it doesn't work, if the narcotics are not working terribly well, right? So make the patient sleep and then wait for the patient to die. That's pretty much how the medication part goes. Now, the bad thing about things nowadays is just like everything else in medicine, things tend to focus on the medication part. So everybody thinks that end-of-life care is a very sophisticated narcotics sedative scheme, but really, if someone's going to die, the care involved is very comprehensive, it's very holistic, and it's not just a matter of providing narcotics or drugging the person up. Okay. Now we have a group of people, a whole bunch of them, just focus on the care, and then a small group who are trying to do the taking care of the people who are dying part, and nobody wants to think about death, and they're the only ones thinking about death. So I wouldn't be surprised if some of the young physicians and nurses would think of this weird, strange group of end-of-life care people like dementors. Like, you feel so bad, this person is going to die, and the family's in despair, and then suddenly let's call the end-of-life care people, or let's call the hospice people. God knows what they'll do. Who knows, right? So it's probably like a group of people who will make this person worse than they are right now. They'll probably traumatize and emotionally push this patient into depression. Who knows? But you refer it to them. We don't want to deal with that. That's pretty much the worst case scenario, but that's not really it. As you would recall, it's just bringing back the idea that even if you cannot take care of the patient, or even if you cannot cure the patient, you should take care of the patient until the very end. And maybe you should also take care of the people who are very much affected with the entire ordeal, like the patient's wife or the kids and the immediate family. So that's pretty much how you define palliative care, or the hospice care or end-of-life care of those who are very close to death. You try your best to take care of the patient. You cannot cure the patient, so you don't think cure. Well, what else do you need to do if you can't cure? Well, the answer is not, well, there's nothing more to do. That's the wrong answer. That's the answer of the 1950s, and that's the answer of a lot of doctors and nurses, mostly doctors. Nurses still think care more than cure. And so what they do? Well, if you have someone who only has 6 months to go, or like 2 months to go, what's the most important thing? Well, maybe the most important thing is to help this person live out those 2 months in the way he wants to live it out. So maybe improve his function, decrease or try to minimize the suffering and the distress, so he can do what he wants to do during those precious 2 months left out of his life. So another way of saying it would be to try to optimize as much as you can. Of course, you cannot make it 100% quality life, but try to improve it as much as you can so that they can live those remaining 2 months in the way they want to live it, right? So advanced heart failure would be a very life-limiting disease, high morbidity and mortality. It has to be said because the initial idea is, hospice care equals cancer care, because cancer care, you see someone with advanced cancer, they cannot cure this person, and you pretty much know that, well, unless a miracle happens, this person's gonna die. Well, and then you just do your best to improve the quality of life. Advanced heart failure, you don't think that way. Well, firstly, because nobody says that, even if it's too obvious, people just keep on doing whatever they can do. And secondly, because it's really not predictable. It's hard to identify at what point you should stop thinking cure, or the cure is less likely, or at what point do you start thinking the patient might actually die in the next few months. We'll go to that later in the talk. But so how does that look? Well, it's bringing back the caring. That's pretty much it. So when you look at this two triangles in the integrative model of palliative care, that's actually all it says in the different ways. So meaning, while you're trying to prolong the life or cure the patient, you don't forget the fact that you should also care for the patient, while you're trying your all sorts of interventions and surgeries or drugs. Some of them would cause a whole bunch of complications and side effects. While you're doing that, you try your best to take care of the patient, make sure that they're coping well, and then try to control any distressing things so that they are not suffering through the entire ordeal. And then once people realize they cannot cure the patient anymore, and the months left is very limited, then we call it hospice care, right? And of course, last 48 hours of life would be the hospice care that takes care of the imminently dying person, and then after the person dies, there's a short few months of bereavement care provided by probably the hospice care nurse or the team, and then the rest of the family goes back to the primary care doctor. That's pretty much how it goes. Now, if you look at this, then you can, from a nursing care perspective, you can easily guess what's required, like life-prolonging care. They're trying to treat the patient. You try to motivate the patient, especially if there's a good chance for cure. There's a social work involved, trying to get the funds if the cost of the intervention is very expensive. And the side effects, the treatment side effects and the complications, you try to take care of the patient. If the patient's throwing up a lot, then you do nursing care, help, and psycho-emotional support for someone who's miserable, suffering through the side effects of the medication or the after effects of the surgery or the intervention. Near the hospice, in the hospice care part or end-of-life care part, the curative part disappears. That's the definition of end-of-life care or hospice care. No more curative part, and you're waiting it out. You still keep on doing what you've been doing as far as care is concerned, but you're the only one left. The cure people are gone, right? So, and then the bereavement part would be taking care of who's left after death. Now, if you really think about it, especially nursing, you know how comprehensive caring for people with how holistic things ought to be, or how comprehensive things ought to be for us to achieve that kind of very ideal goal. So, the care is obviously comprehensive. It's very humane. That's the reason why you're doing it, right? You remain a human person, a human being, even if you're incurable. You're just as human as your doctor or any other patient who can be cured until the end of your life, right? So you deserve to be treated with as much dignity and compassion as the rest of us, right? So it has to be comprehensive and holistic, and involves a lot of things to do if you want to do it completely well. And if we have all the resources available, like in developed countries, it would be nice to have a team to do it, like an interdisciplinary collaborative team, hopefully. Now, that in many places, especially in developing countries, or developing countries who want to call themselves newly industrialized, there's no such team, because that team is very expensive to upkeep, and the return of investment for that kind of team is non-existent, right? So all you can say is, well, it's quality care. It helps us tell other people that we're providing care, but there's not a lot of return for that. Anyway, you also need good communication and advanced care planning. The closer you are to death, the more decisions are possible, and there's no right or wrong decision. It's just that, this is your life. This is your last 3 months of life. What do you want? Do you want this? Do you want this sedated? Do you want this drowsy? Do you want this much pain? Do you want this much alert? Do you want to go here? Tell us what you want. We'll try to come up with a way to achieve that. So that's pretty much what advanced care planning is. That's the general idea. Of course, when I talk about advanced care planning in the very medicalized form of palliative care, we just talk about the medical part. Do you want this drug for the blood pressure? Do you want the ventilator? Do you want this inotrope? Do you want the antibiotic? Do you want the antibiotic? Do you want the dialysis? And those kinds of things. But that's not really the only thing you want to know, right? So how do you want your life to be during the final 2 months? That's pretty much the most important question you have to ask, because you'll do everything that you can to help the patient out, right? Okay, so now the problem with heart failure and palliative care is this. It's not like cancer, like I said. You get heart failure, and then suddenly you go through the heart unit or the heart center, and then you get fixed up with inotropes and diuretics and other interventions, and then you go back home feeling kind of okay, and then another episode happens, and then you get into the heart unit again, and then you get sicker after a few times of in and out admissions, and then you improve but not as good as before, and then in the long run you're actually getting worse, and then get admitted, and then you come out. But if you really take a look at what's happening, this person is actually gradually getting worse and worse. The only difference is it's not that obvious, right? And nobody's saying it, right? In cancer, you cannot be cured, and then they're watching you get worse. Then everybody knows that since you cannot be cured, you'll end up dying, and people see a straight line all the way down. In heart failure, you can see the trajectory all the way down for those with really advanced progressive heart failure, but you can only see it if you want to see it. But not a lot of people taking care of heart failure patients would want to see that, right? So if you don't see it, or you don't want to see it, when do you think end-of-life care or hospice? Because end-of-life care or hospice means you accept the fact that no matter what you do, it will end up that way, and no matter what you do, the patient is really, really close to dying, even if it looked like you were able to save him this time. Okay? So there's the confusion when who's responsible, who does the caring part, especially heart failure. It's becoming highly medicalized. You have all sorts of devices and procedures and things like that. People seem to think they'll live on forever and with a bionic heart or something. Of course, that's not true. And we also have like, you get put on like 4, 5, or 6 medications, and the patient is thinking, well, if it's 6 medications costing this much, I probably am saved already, which is not true also. But so really nobody's thinking getting worse near death. People are just thinking, what's the other stuff that we can do to this person to prolong his life? And nobody's telling the patient how much really can they prolong his life with all the stuff they're doing to him, right? So there's confusion, and even the care team don't want to think about it. So when do you start putting more attention to care? Well, the best solution would be, no matter what you're doing, pay attention to the suffering, the distress, and stuff, right? So that would minimize the uncaring part. And of course, the harder thing to do is to accept reality. Every now and then you stop. If you're the nurse or the doctor, look at the patient and just think about the past 6 months or the past 12 months and be honest and tell yourself what's really happening. And if you want to help the patient out and take care of the patient, you should also be honest to the patient, because you want to know how the patient would want to live out his 4 to 6 months of life. I mean, not a lot of people would want to live out 4 months of their life trying to prolong their life for 4 days, or trying out interventions that cost a lot but with a very small chance of working, right? So you probably would want to have other things in mind if somebody asks you that question. So now people come up with ideas like, when do you refer? And then they come up with, like, maybe at this stage, maybe when they have all these bunch of symptoms and things like that. But in resource poor countries, the problem is you don't have all these care facilities and care manpower to do all these things. And the simplest suggestion is, if you're a nurse and you're looking at the patient, or if you're the doctor or nurse and you're looking at the patient and you see the heart failure is getting worse, obviously, and you see a lot of distress and symptoms and suffering, maybe it's about time to pay more attention to the comfort and the care part, right? So regardless of what the classification of the heart failure is, or regardless of what other parameters were suggested, I mean, that's the simplest way of looking at it. So now, communication part. Well, unfortunately, when they started reintroducing end-of-life care, they realized a big problem is the care providers just don't communicate. Now, of course, the nurse is excused because you're not allowed to say anything that the doctor doesn't want you to say. But the doctors are probably the bigger culprit. They really don't communicate well. So when they created end-of-life care modules for doctors, like 1/3 of the entire thing. I mean, imagine you need to teach these physicians a lot of stuff, or basic stuff, so that they can take care of the patients who are dying. Those they cannot cure. Obviously, they cannot cure everyone. Well, sometimes you even have to teach them that. Remember, you cannot cure everyone, because I don't think they teach that a lot in med school. Right, so like, the patient is dying. What did you do wrong? Maybe you should have done better. Something like that. And you stand in front, mortality and morbidity, thinking you're an idiot, right? So you try to study better so that you can cure everyone who passes through your door. And the problem with that is, even your the consultants and the smart people telling you that you did wrong cannot keep all their patients alive. Nobody could, right? So there's this, you're not a demigod. So sometimes you just have to tell the doctors that because they keep on forgetting, or they don't want to think about it. And you don't need that narrative to be a good doctor. Actually, it makes you ineffective, and it doesn't make you any, and you don't need that narrative to be a good doctor. Anyway, so it's very simple. I mean, what I tell the students would be, imagine you're that person lying on bed and you have a life-ending heart failure and you're feeling all these symptoms, and not unless you're not thinking straight, you can pretty much tell you're getting worse even if they don't tell you, right? Based on what they're doing to you and based on what you're feeling, and you're asking them to tell you, and then so the nurse or the doctor will communicate the prognosis and the bad news, right? So what do you do? Well, first off, you have to figure out what the patient already knows, okay? And this is a very useful thing to do because most of the time they understand a lot, or they have guessed a lot, and you don't need to start from step one or from, because they already have a good understanding. And then you give them the bad news. You might live 2 to 4 months. Now, one good excuse, which is not really an excuse, is, well, we can't really tell. What if we tell them 2 months and it's actually 1 month? Or what we tell them 3 months and it's actually 4 months? Well, the answer to that is, does the patient care? Not really. So, but they do want to know if it's short, right? So give them a range. That's the advice, like, as far as we can tell, or based on our experience, most patients would usually have a prognosis of 2 to 4 months. Now, some might die earlier because of a sudden complication, or some might live longer, but a lot would die between 2 to 4 months. So that's the news. Don't wait for anything to be uncertain because there's no such time, right? So you're just using it as an excuse not to say anything, right? So and then you prepare the patient emotionally, because your plan is to deliver the news so that they can absorb it well, so that they can think about what they want out of life, so that they can tell you, and so that you can help them out. You don't want someone with traumatic disorder or someone with severe depression, because that's not going to help, right? So actually that made things worse. And then you talk about their life goals. That's really what telling you what they want out of life means. What that would be based on their values and things like that. Now, the more narrower definition of preferences would be things about CPR and ventilators, and that would go along with that. But remember, it's much more than that. It's how the patient wants to live out the rest of their life. How the patient wants to live out the rest of his or her life, and how he wants to die. That's what it is. So don't just ask about CPR and ventilator, because that's not the only thing that matters. Okay, it's not even the most important thing that matters for a lot of people, especially those who are spiritual or religious, and that would be 80 to 90% of your patients in many countries or communities. There are much more important things than the ventilator or the CPR. So involve the priest or the pastor or the nun or the pastoral care services, because they become more and more important. At some point, they become more important than the doctor who can't do anything more, right? So, and then you suggest that you want to plan for the worst, and the common phrase would be, we're praying with you, we're hoping that you live long so that you can do all the stuff you still want to do. But it's also good to plan for the worst. Hopefully it doesn't come too soon, but so that we're prepared. It's good to be prepared. That's one way of looking at it. I mean, it certainly sounds better than, you're certainly going to die. You might as well prepare yourself. I mean, that sounds bad. It's actually the same message, but the way it's said, the first one is better, right? So, we care for you. We're really hoping that it won't happen too soon, but we want to do whatever you want. Some people don't want CPR. We don't want doing stuff that you don't actually want, and it also can be shocking for people if it suddenly comes. So hopefully it doesn't come too soon, but we want you prepared, and we want us prepared. So we know if you want a ventilator, so we know what you want us to do, and we know what you don't want us to do. That's one way of doing it. Okay, so advanced care planning can be said in a very non-threatening way, or you can do advanced care planning in a very non-threatening way. It's actually very empowering if you do it that way. So now, if we will just go briefly through symptom control. We don't have time to discuss everything, of course. This is like one huge workshop, and there are several symptoms, not just these things, but you might see shortness of breath. Okay, so now the idea for all these symptoms is that it's heart failure, right? So what's happening, and the possible stuff causing the shortness of breath. Now, whatever still works, do that first. Don't just grab the morphine and drug the person up. Whatever still works, do that first. Now, at some point close to death, when the heart failure has progressed that far, none of the usual stuff works, and so the narcotics or the opioids take away the feeling of shortness of breath. Like you're still short of oxygen, your body still craves it, but your mind tells you it's okay, so you don't suffer that much, right? So that's pretty much how it works, and so it takes away the sense of shortness of breath. It doesn't fix it, but it takes away the distress and the suffering. Now, benzodiazepines work different. If that doesn't work, then make the person sleep or sedate the person heavy enough so that they don't feel it too much. I mean, a comatose person doesn't feel anything. Of course, you don't need to sedate everyone into unconsciousness. Like that's really the last resort. Sometimes you really need to do that for a very, very, very few cases, but most of the time you just need the combination of narcotics and sedatives very near death. Sometimes you don't even need that because the body itself produces its own narcotics or morphine-like substances, and the body sedates itself, right? During the dying process, dying people become more and more sedated. The consciousness goes down. So that's actually the natural method for the body to prepare itself for death. So now, if the natural stuff doesn't work, then you can help it out by giving it a little bit more narcotics and a little bit more sedation, right? For some cases, not all cases. Pain, some people would feel pain. It could be chest pain, like angina kind of pain that's getting worse and worse. Your oxygen is dropping, and your body's under stress. It's about to die, and the narcotics would be the main thing. You don't need to be scared of narcotics. The patient's about to die, so, and you don't need to risk the NSAIDs, especially if the patient clearly has a significant risk for renal failure or GI bleeding or stuff like that, right? Definitely you're not holding back on the opioids or the sedatives because you're worried that the patient will get addicted. Like, if someone has like 2 weeks to live or 2 months to live and is clearly experiencing a lot of stuff, you don't worry about addiction, right? So they really need it. Now, the depression can happen. Now, this one is a very tricky one. Like, we know that the drugs only help so much, and then very near death, they're less effective, right? So it's really a lot of communication, supportive counseling, and you hope that your drug kind of helps out also. That's pretty much how it works. And just because you don't have a quick fix drug, it doesn't mean you don't pay attention to it. Emotions and like depression, anxiety, and fear, and things like that become more and more important as you get closer and closer to death, right? Because the death part is real, and it's very natural for anyone who knows that they're about to die to feel all sorts of emotions. And sometimes they need help because those emotions are becoming too much to handle for them. And then the fatigue. Now, fatigue, of course, it's hard to fix if someone's about to die. Everyone gets weaker and weaker. But earlier on, like they have 6 months to live, and then of course the idea is for them to be able to do what they want to do out of life. Then you try to optimize their functions so that they can do that, right? And you keep on trying it as much as it's doable, right? So as far as it's doable now, at some point they're just bedridden, but you think about it earlier on. So that's pretty much it. So when you think about hospice care, palliative care, supportive care, really what it is nursing care. Really what it is nursing care. Okay, nursing care that was there before. We didn't stop doing proper holistic humane care when the doctor says the patient is terminal. You don't stop caring for patients. So that's what it is. It kind of disappeared a little during the 1950s, and then we brought it back, and then we called it hospice nursing care, or we called it palliative and hospice care. So it's pretty much the same thing, right? And it's naturally holistic, it's humane, right? And if we really want to do it well, it would require a lot of resources, because the more people doing it, more stuff we can do, right? It's very difficult for one person to do, but if you're that one or two persons, or if you're just 2 nurses taking care of the patient, you still try your best to be as holistic and humane as you can possibly be, right? Especially doctors, they should try harder to be more compassionate, more holistic, and more humane as they can possibly be, if there's anything left in there somewhere. So I hope you got something out of this, and thank you for listening.